Hello, future nurses and NCLEX champions. Welcome back to NCLEX, the most trusted space where nursing knowledge transforms into real confidence and exam success. Here, we bring you 2 to 3 high-impact NCLEX videos every single day, each one designed to simplify complex concepts and turn them into crystal clear understanding. In today's critical care focus session, we are diving into a life-threatening emergency that every nurse must master: pulmonary embolism. A pulmonary embolism is a medical emergency caused by a clot that travels to the lungs, blocking blood flow and endangering oxygenation. In this lesson, you will learn to identify early warning signs, such as sudden shortness of breath, chest pain, and tachycardia, as well as priority nursing actions like maintaining oxygenation, positioning the client properly, administering anticoagulant therapy, and preventing future clots. You will also gain insight into diagnostic procedures, post-treatment monitoring, and client education, all crucial for both NCLEX preparation and real-life nursing excellence. So stay tuned till the very end and take notes carefully, because this topic can easily appear in your exam as a high-priority question. And remember, at NCLEX, we do not just teach you to pass, we prepare you to think like a lifesaver. Let's begin today's essential session on nursing care of clients with pulmonary embolism.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now transition into an advanced-level clinical reasoning question that tests your understanding of post-operative complications and embolic pathophysiology. Imagine this: a post-operative client who recently underwent abdominal surgery suddenly develops acute shortness of breath, sharp chest pain that worsens with inspiration, and a terrifying sense of impending doom. The nurse immediately suspects a pulmonary embolism. The question is, based on the pathophysiology of embolic formation, from which site did the embolus most likely originate? Moving forward to the options, let us analyze each possibility carefully. Option A, deep veins of the legs. Option B, pulmonary artery. Option C, superior vena cava. Option D, carotid artery. The correct answer is option A, deep veins of the legs. To understand why this answer is correct, let us explore the advanced rationale behind it. A pulmonary embolism occurs when a clot, fat, air, or amniotic material lodges within the pulmonary vasculature, obstructing blood flow to part of the lung. The most common origin is a thrombus that forms in the deep veins of the lower extremities, especially the femoral, popliteal, or iliac veins, a condition known as deep vein thrombosis. Once dislodged, the thrombus travels through the venous circulation, passes the right atrium and ventricle, and ultimately lodges in the pulmonary artery, creating an obstruction that leads to a mismatch between ventilation and perfusion, ultimately causing hypoxemia. Now transitioning into the clinical mechanism, after abdominal surgery, several risk factors combine to increase the likelihood of venous thromboembolism. Venous stasis develops due to immobility and bed rest. Endothelial injury occurs from surgical manipulation, and hypercoagulability arises from tissue trauma and hormonal stress responses. These 3 elements, venous stasis, endothelial injury, and hypercoagulability, are collectively known as Virchow's triad, the classic foundation of thrombus formation. When such a clot migrates to the lungs, it increases pulmonary vascular resistance, impairs oxygen exchange, and can strain the right ventricle, leading to acute cor pulmonale or even sudden death. Clinically speaking, a pulmonary embolism typically presents with sudden dyspnea, pleuritic chest pain, restlessness, tachypnea, tachycardia, and sometimes cyanosis or syncope. The nurse should act promptly by administering oxygen, elevating the head of the bed, notifying the healthcare provider, initiating anticoagulation as ordered, and ensuring continuous monitoring. Let us now examine why the other options are incorrect. Option B, pulmonary artery, is incorrect because this is the site where the embolus becomes lodged, not where it originates. The clot travels from the venous circulation before reaching the pulmonary artery. Option C, superior vena cava, is also incorrect since it drains venous blood from the upper body, and emboli from this region are uncommon, usually linked to central lines or pacemaker leads, not postoperative immobility. Option D, carotid artery, is incorrect because emboli from this vessel lead to cerebral infarctions or strokes, not pulmonary embolisms. Arterial emboli arise from the left side of the heart or atherosclerotic plaques, not venous thrombi. Transitioning into the STANCOAST, clinical insight. After surgery, the body's clotting defense shifts from protection to potential peril. A single venous clot born silently in the leg can swiftly reach the lungs and endanger life within seconds. The vigilant nurse's role in prevention, through early ambulation, leg exercises, and compression devices, is not merely routine, it is life-saving. Now moving to the Stand-Coast High-Yield NCLEX Pearl. Always suspect pulmonary embolism in a post-operative client who suddenly develops dyspnea, chest pain, or restlessness. Remember, the primary source is deep vein thrombosis of the lower limbs. Focus on prevention through early ambulation, leg elevation, use of sequential compression devices, and prophylactic anticoagulant therapy. And finally, during emergency management, administer oxygen, notify the physician, position the client in semi-Fowler's position, and prepare for anticoagulation or thrombolytic therapy to restore perfusion and prevent recurrence. Let us now move into a powerful clinical scenario that tests both your communication and crisis management skills. Imagine this. A client suddenly clutches their chest, gasping, "Nurse, I think I'm dying." The atmosphere is tense, the client's fear is palpable, and the nurse must respond immediately. The question is, what should the nurse say in this critical moment? Here are the options to consider. Option 1, the pain will lessen in a few minutes. Option 2, I will stay with you until the physician comes. Option 3, why would you even think something like that? Option 4, are your financial affairs in order? The correct answer is Option 2, I will stay with you until the physician comes. Now, let us explore the expanded advanced rationale behind this. When a client expresses fear of dying, it is a manifestation of intense anxiety often associated with physical distress, whether due to myocardial infarction, pulmonary embolism, or severe panic. The nurse's foremost role is to provide therapeutic presence, ensuring both emotional stability and physical safety. Saying, "I will stay with you until the physician comes," is the most appropriate therapeutic response because it shows empathy, reassurance through action, and emotional grounding. This statement does not make empty promises or offer false reassurance. It simply assures the client that they are not alone. Presence itself becomes a therapeutic tool, fostering calmness, reducing panic, and promoting trust between the client and the nurse. Furthermore, this response aligns perfectly with NCLEX frameworks, focusing on psychosocial integrity and safety and comfort needs. A nurse who remains composed and reassuring helps regulate the client's anxiety and prevents sympathetic overactivation, such as increased heart rate or breathing difficulty, which could worsen the crisis. Ultimately, emotional support and calm presence represent essential nursing interventions in emergencies, helping bridge the gap between fear and safety. Moving on, let us carefully evaluate why the other options are incorrect. First, option 1, the pain will lessen in a few minutes, is inappropriate because it offers false reassurance. The nurse cannot predict the client's clinical course and should never minimize distressing symptoms. False reassurance invalidates the client's feelings and may delay necessary emergency interventions, directly contradicting NCLEX principles of honest and empathetic communication. Next, option 3. Why would you even think something like that? Is also non-therapeutic. Why questions often sound accusatory or judgmental, putting the client on the defensive and discouraging emotional openness. In moments of fear, clients need validation, not interrogation. A therapeutic nurse responds with empathy, not curiosity. Lastly, option 4, are your financial affairs in order? Is completely inappropriate and insensitive. Bringing up financial concerns during a medical emergency trivializes the client's distress, neglects urgent physiological needs, and violates ethical nursing practice. Such a comment shows poor judgment and disregards the ANA Code of Ethics, which emphasizes compassion, respect, and patient-centered care. Transitioning to deeper reflection, let us now uncover the Stan Coast clinical insight. Before revealing our final takeaway, let us pause for a reflective moment. In times of acute crisis, when fear and physiology collide, the nurse's calm presence becomes the anchor that steadies the storm. A steady voice, gentle eye contact, and simple words like, "I am here with you," can lower anxiety more effectively than any medication in that instant. And as we summarize this concept, here comes the Stan Coast High-Yield NCLEX Pearl. Therapeutic communication during emergencies is built on presence and purposeful silence, not promises. Remember this formula: calm presence plus empathetic action equals psychological safety. Avoid false reassurance or why questions, as they block emotional expression and trust. Always stay with the client, assess airway, breathing, and circulation, call for help, and continue offering both emotional and physiological support until the situation stabilizes.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us smoothly transition into a high-acuity emergency scenario that demands both rapid assessment and precise prioritization. A nurse is assessing a client who suddenly develops acute shortness of breath, chest pain, and anxiety. The client appears restless, tachypneic, and slightly cyanotic, all red flag indicators of impaired oxygenation and possible cardiopulmonary compromise. Now the question arises: which nursing intervention is the most critical and immediate response to the client's current physical symptoms? Here are the options to consider. Option A, administer oxygen by face mask. Option B, assess the client's capillary refill. Option C, have the client rate the pain on a pain scale. Option D, request a physician's order for cardiac enzymes. Correct answer: Option A, administer oxygen by face mask. Let us now delve into the expanded advanced rationale behind this life-saving action. When a client suddenly exhibits acute dyspnea, chest pain, and cyanosis, the nurse must immediately suspect a respiratory or circulatory crisis such as pulmonary embolism, acute myocardial ischemia, or pneumothorax. In all these emergencies, oxygenation is the top physiological priority, acting within the ABC framework: airway, breathing, and circulation. The nurse must first ensure that oxygen delivery is optimized to sustain vital organs. Administering oxygen via face mask raises the inspired oxygen concentration, combats hypoxemia, relieves dyspnea, and reduces myocardial strain. This single intervention can prevent progression to cardiac arrest while buying time for definitive diagnosis and treatment. Once oxygen is initiated, the nurse should continuously monitor respiratory effort, oxygen saturation, and level of consciousness to evaluate response. Moving on to the alternatives. Assessing capillary refill, option B, provides useful information about peripheral perfusion but does nothing to reverse hypoxia. It should follow, not precede, oxygen administration. Having the client rate pain, option C, may aid in pain management later, but when oxygen deprivation threatens survival, subjective assessment must wait until the airway and breathing are stabilized. Requesting a physician's order for cardiac enzymes, option D, is appropriate once the client is stable and myocardial infarction is suspected. Yet waiting for diagnostic orders while the client gasps for air delays essential life support measures, a potentially fatal error. Transitioning to deeper reflection, let us now uncover the Stan Coast clinical insight. When seconds separate stability from collapse, oxygen becomes the purest form of medicine. The nurse's calm, decisive act of delivering oxygen can transform panic into preservation, ensuring that every heartbeat still carries life to the brain and vital organs. And as we summarize this concept, Here comes the Stand Coast High-Yield NCLEX Pearl. Always apply ABC prioritization, airway, breathing, circulation, before any diagnostic or comfort measures. Remember, oxygen is both a treatment and a diagnostic clue. If symptoms improve after oxygen, the problem is likely respiratory in origin. Never delay oxygen therapy while seeking orders or assessing pain. In any suspected pulmonary embolism or acute coronary syndrome, administer oxygen first, then promptly notify the provider for advanced management. Let us smoothly transition into another high-acuity clinical scenario that demands sharp critical thinking and rapid prioritization. A nurse is caring for a client who suddenly develops acute shortness of breath, pleuritic chest pain, tachycardia, and anxiety. The client's oxygen saturation has dropped to 84% on room air, and an arterial blood gas shows respiratory alkalosis due to hyperventilation. The healthcare provider suspects a pulmonary embolism, also known as PE. Now the question is, based on this clinical presentation, which medication should the nurse anticipate will be administered intravenously to stabilize the client's condition? Here are the options to consider. Option A, heparin. Option B, aminophylline, also known as trufilline. Option C, nitroglycerin, commonly referred to as nitrodisc. Option D, aspirin. The correct answer is option A, heparin. Now, let us dive deeper into the expanded advanced rationale behind this choice. When a client presents with the classic triad of sudden dyspnea, chest pain, and tachycardia, especially in the presence of hypoxemia and anxiety, the nurse must immediately suspect pulmonary embolism, a potentially fatal obstruction of the pulmonary artery that is often caused by a thrombus migrating from a deep vein thrombosis. In this emergency, the primary goal of treatment is to stop further clot formation and prevent existing clots from enlarging. Intravenous unfractionated heparin becomes the cornerstone of rapid anticoagulation therapy. It works by enhancing the action of antithrombin 3, which inhibits clotting factors 2A, thrombin, and XA. This interruption in the coagulation cascade halts the formation of new clots and allows the body's natural fibrinolytic system to dissolve the current embolus gradually. As the client stabilizes, therapy transitions through a systematic sequence. First, intravenous heparin for immediate anticoagulation. Next, subcutaneous low molecular weight heparin, such as enoxaparin for continued management. And finally, oral warfarin for long-term anticoagulation. The transition to warfarin occurs only when the international normalized ratio, or INR, reaches the therapeutic range of 2 to 3. During this process, the nurse must carefully monitor the activated partial thromboplastin time, or a PTT, maintaining it at 1.5 to 2.5 times the control value. It is essential to observe for signs of bleeding, such as hematuria, melena, or hematemesis, and avoid unnecessary invasive procedures. Additionally, protamine sulfate should always be available as the antidote to reverse heparin toxicity if it occurs. Moving on to the other options, option B, aminophylline, trufilline, may initially sound useful due to its bronchodilator effects, but it is actually used for conditions like asthma and chronic obstructive pulmonary disease to relieve bronchospasm. It has no role in treating a pulmonary embolism, where the problem lies not in airway constriction, but in vascular blockage. Administering aminophylline in this case would only delay life-saving anticoagulant therapy. Next, option C, nitroglycerin, nitrodisc, is typically prescribed to relieve angina pectoris by dilating coronary arteries and reducing myocardial oxygen demand. However, in pulmonary embolism, the issue arises from obstruction in the pulmonary circulation rather than a cardiac ischemic event. Using nitroglycerin could even worsen hypotension due to right ventricular strain, thus aggravating the client's instability. Finally, option D, aspirin, though widely known for its antiplatelet effects, is primarily effective against arterial clots that form in conditions like myocardial infarction and ischemic stroke. Pulmonary emboli, on the other hand, are venous clots composed predominantly of fibrin and red blood cells, which respond best to anticoagulants, not antiplatelet agents. Therefore, aspirin would not be effective in this emergency. Transitioning now to the clinical wisdom derived from this case, here is the Stand Coast clinical insight. In pulmonary embolism, the threat does not come from bronchospasm, but from a blood clot that silently blocks life-giving oxygen. Heparin becomes the nurse's immediate ally, halting the dangerous cascade of coagulation and granting the lungs a vital chance to recover. And to conclude with a Stancoast high-yield NCLEX Pearl, always remember, sudden, unexplained dyspnea, chest pain, and tachycardia, especially after surgery or prolonged bed rest, should raise your suspicion for pulmonary embolism. Intravenous heparin is the first-line intervention for acute stabilization. Continuously monitor a PTT levels, platelet counts, and bleeding indicators, and always keep protamine sulfate within reach as the reversal agent. Lastly, recall the golden sequence for anticoagulation therapy: heparin, enoxaparin, warfarin, a continuum that ensures clot control and long-term protection.